let's talk about schizophrenia, shall we?
Yes.
It is a mental disorder. Did you know?
Mm-hmm.
Okay, so we have a good start. See? All right. Biggest thing you need to know about schizophrenia is they are completely broken from reality. Like, you cannot orient them. You know how they always tell you in nursing school, orient. They live on a different planet. Okay? And what they see and what they hear and what they feel is real to them. It is right straight in front of them. Okay? So for you to deny their reality or to try to pull them into your reality will never happen. They believe what they believe, and you will never be able to change it. So you treat this one, that's why I really want to do this one in person. This is completely different than all the other mental disorders. All the other ones, you try to root them in reality and bring them back to the present day. They don't live that way. They live in a completely different world where they are hearing voices and seeing people and seeing things and seeing animals. And it's a very, very scary world that they live in. Okay? So you cannot say that what they see isn't there, because it is literally right there. And it will make them more crazy if you try to do that. You see what I'm saying?
Yeah.
Okay. It's like if I see you take a drink of your cup right there, and then I'm like, what are you doing? You don't even have a cup. And you're like, yeah, I'm drinking it. No, you don't. There's no cup there. And you're like holding it in your hand, so you would think like, am I okay? Right? And so it makes it more confusing. So if you can't say it's not there, then what therapeutically can you say? Like, I'll give you a for instance. Schizophrenia patient says, oh my God, there's a snake right by my foot. And they're freaking out.
Like, I know it's there, but it's not going to hurt you, maybe?
But can you promise that?
Can you show me where?
Okay, and then what? Y'all gonna go snake hunting?
Mm.
She said, oh no. You don't want to go into their reality either. And you can't pull them into yours. All you can state is your reality. You can state your reality, but you can't pull them out of theirs. So you can say, I don't see the snakes, but you sound really scared. Why don't we go in the hallway? I'm not playing into your delusions. I'm not playing, you see what I'm saying? Like, I'm not playing into like oh, there's a snake where? Ha ha ha. You know, okay. I'm also not saying it's not there. I'm just saying, I'm sorry, I don't see it, but you look really scared. Do you want to go outside? We'll go to the day room, or I can go walk with you in the hallway. Okay. So that is the appropriate nursing way to communicate with these patients only. Every other disorder is not like that. And that's because they're not rooted in reality. Okay? And you can't pull them out of theirs, and you can't go into theirs. Okay? Because that's a whole ball of something you don't want to really get into. And their hallucinations, delusions, all these things they're thinking and feeling are not rooted in anything else. Like, it's not something you could sit down and be like, so why do you think you see snake? They don't know. They're just appearing. It wasn't like they had a snake experience as a child that was scared. It's not like that.
Yeah.
Okay? All right. So let's start at the top. This one has a genetic predisposition plus a trigger. What does that sound like? What kind of diseases have a genetic predisposition and a trigger? I'm not talking about mental disorders. I'm talking about like medical disorders. We've probably talked about them 1,000 times. There's a genetic predisposition plus a trigger, and then the body starts attacking itself. What diseases? It's autoimmune disorders. It sounds like autoimmune disorders because there's a genetic predisposition and a trigger, but they haven't proven that it's some kind of autoimmune, but it does happen very quickly after some kind of big trigger. Usually it's like a massive grief, like you have lost somebody very close to you, or a massive traumatic event. Something happens and you just pop into schizophrenia. Isn't that wild?
That is crazy.
I know. So like illness, a major illness can do it too. You could get really, really sick and end up in the hospital and then come out schizophrenic. Drugs can do it. Now I can understand drug induced because that can mess with your mind and things like that. That one kind of makes sense to me. Okay. All right. So risk factors, obviously genetics and family history. I mean, schizophrenia has a very strong family history. Like if your mama or your daddy has it, you probably at some point in your life will get it. Viral infections like HSV. What's HSV? Y'all killing me today. It's like dead silent here.
It's a virus.
It is a virus. Good start. Good start. There's a 1 and a 2 if that helps you. HSV1 and HSV2. Herpes simplex virus. John, the herpes simplex can cause you to get schizophrenia. Don't worry, just a cold sore, and then bam, there you go. Okay. Lead exposure. Now that one makes sense to me because any heavy metals will go to the brain. We know that. Like in kids, if they have lead exposure, they can get lead toxicity and things like that. Here's a wild one. Poor maternal nutrition. So if your mom did not have good nutrition while she was pregnant with you, you could end up schizophrenic.
And this is only if you have the genetic.
Usually it's just a genetic predisposition, but this is not a genetic disease.
Okay, so you can.
A predisposition just means like you have a gene for it, but it's not on when you're born.
Okay.
But something, one of these triggers can turn on that gene, and then bam, you have schizophrenia.
Okay.
Okay. So it's not a genetic disease. Do y'all understand what I mean? It's not a genetic disease, but it has a genetic predisposition. Okay. All right. A crowded living environment. Now that's not going to by itself just going to cause schizophrenia. You would have to have some of these other things, right? But just living in some kind of environment that is packed with people. We see it a lot in the homeless population, right? So like poverty, severe stress, things like that can put you more at risk. African Americans are the most at risk for schizophrenia. And if you have had a traumatic childhood that you have not dealt with, that's another big risk factor. Okay. Mm-hmm. Schizophrenia also, for whatever reason, has a big hormonal component to it. So a lot of patients will end up becoming or having schizophrenia as they're hitting puberty, which is pretty crazy to me. All right. There are different types, and these get kind of spicy. So are y'all ready? You might just want to give yourself a couple keywords here. There's something called delusional disorder where they just have delusions. What are delusions?
You're seeing things?
That's a hallucination.
It's not here.
So a hallucination is something that you experience with your five senses. You either taste it, see it, hear it, feel it, right? Mm-hmm. A delusion is something you believe. The government is after me. They've been chasing me for years. Mm-hmm. And quite honestly, y'all, I believe some of these people. So whenever they have like schizophrenia and they keep telling me stuff, I'm kind of like, because I saw this TikTok, and I know TikTok is not the end-all be-all, okay? But I am with friends of a lot of nurses on there. And there was one that was at a mental health facility, and they were like, oh, yeah, this lady got admitted for schizophrenia because she would not stop saying that the government was after her. And they're like, until one night I was working night shift, and these two guys in a black suit came to the unit and held up their government badges, were like, we're here to see this lady. And he was like, well, do you have, like, something that says that you can see her? And he's like, no, but we have government clearance. And they came and took the lady, and she was gone. And he was like, she was right, you know? Anyway, so that's delusional disorder, is you just have different beliefs, right? You have beliefs that something is happening. A brief psychotic disorder is when you go into what looks like schizophrenia, but it lasts for less than a month. This is usually after a major, like, shocking trauma that you didn't expect. There is substance induced, so you get schizophrenia from drugs, or medically induced, where something happened to you medically, like you had a medical disease, and then you ended up getting schizophrenia. Catatonic disorder. Have you ever heard of somebody being catatonic? That's catatonic. Did I scare you?
I was like, what? I was so
confused. Catatonic is where there's like nothing, and you can like put their hand in front of their face and like they just sit there. Okay. So they have stupor where they're just, and rigidity where they're like stiff as a board where they're just sitting, and no facial expressions. They don't respond to you in any type of way.
Ever?
Okay. Not usually. You've probably seen these in movies before. They're always in a rocking chair and they're just staring out the window. Okay, that's what catatonic is. Okay. Did I freak y'all out?
Yeah.
I don't think I had a stroke or something.
Oh no, I was just confused because she looked that way, so I was like, what's going on?
All right, there is something called schizophreniform where it lasts more than a month, so it's not a brief psychotic disorder, but it's less than 6 months. Like you just went through it for a period of time and then it resolved. Okay. And then there's schizoaffective disorder where you also have a mood disorder on top of it. Like, what's the most common mood disorder?
Like bipolar?
Yeah, like bipolar or something like that. Okay. All right. Biggest thing to note for schizophrenia, they are not rooted in reality, right? Okay. So you cannot pull them into yours, and you do not want to go into theirs. Okay? Mm-hmm. All right. Schizophrenia affects their thought process, their perception. What's somebody's perception?
Like what you think of something?
What you think is going on. So they may be, with some kind of situation happens, and their perception may be like, you okay? You know, like it's wildly different than anybody else's. Mm-hmm. And their affect. What's an affect? You'll see this a lot in psych. Like they may say somebody has a flat affect. What does that mean? Anyone? It's what your face looks like. Okay. So if you're coming in and talking to me, like when you came in earlier, right, I was like, hey, how are you? And you came in, I'm like, oh, your hair looks so good. My affect is great. I'm smiling and I'm interacting and blah, blah, blah. But patients that have schizophrenia or in catatonia, they may have a flat affect where, yes, I'm very happy today, or I'm having a very bad day. Their emotions don't change. You can't see any change on their face. Okay. So an affect is, what does your face look like? Okay. All right. There are 4 different phases of schizophrenia. Like somebody just doesn't wake up one day and like, bam, they're schizophrenic, but you could have seen some red flags along the way. Okay. So the first one is called a pre-morbid phase. Pre-morbid. Okay. Where they are withdrawn and they're very lonely, and you start to notice like, dang, I've been asking them to go places and they don't want to go. They become just very like not socialized, and they just get like really all to themselves. They get what's called antisocial behavior, which basically means like, I don't want to be around you. I don't want to be around anybody. You go and you knock on their door. They don't answer. You call and you ask them to go places. They either don't answer the phone or they say no. Okay. So pre-morbid, which means before the morbidity, before this happens. Then you go into prodromal. In nursing, what does prodromal mean? Anytime you see like prodromal symptoms, what does that mean? You get it in a lot of diseases. You get prodromal for hepatitis. You get prodromal for migraines. You get prodromal for flu. You ever felt like right before it starts? You know how like if you're going to school or something, you're like, man, I don't feel that good. I think I'm about to get sick. Like I don't have cough, I don't have kind, but like I feel it's coming. That's what the prodromal phase always will be in nursing school. So if they ever ask you what's in prodromal, it's going to be very non-specific symptoms. Fatigue, malaise, whatever. But for a mental disorder, they start to have real functional impairment. Like they are very anxious, very irritable. When people come over, they don't want them to come over. They want you to leave. They're not sleeping. They're up usually pacing, but they're really tired because they're not sleeping, right? They get very depressed and they become very paranoid and suspicious of other people. So most of the time they're just staying in their house or looking out the window. Oh, that was not the same mailman as yesterday. I think that guy must be hired by the government. They're trying to trick me, right? They're trying to trick me. And you can't be like that around other people because people think you're weird. So they start to socially really withdraw. Okay. Then they're going to go into full out schizophrenia, where this is a complete psychosis with hallucinations and delusions. Okay. What are hallucinations and how are they different than delusions?
Seeing.
So hallucination is one of the 5 senses. So let's go over them. Okay. Write it down in the notes somewhere. All right. You've got, if you are seeing something that is not there, what are those called? That's this one.
Oh,
visual hallucinations. That was an easy question.
I always try
visual hallucinations. All right, what about ones that you're hearing? That's auditory hallucinations. What about ones that you feel? You could feel something crawling under your skin, or you can feel bugs or aliens grabbing you. What's it called when you touch something? What type of learner are you if you have to have your hands on something? It starts with a T. Tactile. Yeah, you're about to say it. Oh, you said it at the same time as me. Tactile. What about taste? They taste something that is not there. Starts with a G. I don't know if y'all know this one. Gustatory. Nope. Okay. Gustatory. Smell. What cranial nerve? What cranial nerve assesses your smell? Oh, crap. That didn't help you.
No.
The way I remember this one is I always say you smell an old factory, like an old factory smells.
Oh, olfactory.
Olfactory. Oh, she's like, I got this one. All right. So hallucinations are something that you are experiencing with your 5 senses, whereas delusions are something that you believe, right? You're believing something. I believe that I am the Messiah. Okay. God has sent me here to tell y'all you're going to hell. Okay. Have y'all seen like a lot of people, like, have you ever been to New Orleans?
Oh, well, I've been there, yeah, a long time ago.
Oh, that's right. Have you been there? Well, you go there and there's going to be somebody on the corner with a big old sign that's like, you're going to hell. You know what I mean? Yeah. All right. Then after, you can't really say after the schizophrenia, but as the schizophrenia continues to go on, you may start to get residual symptoms. What does residual mean? Like if you're doing your residual urine, what does that mean?
Like after?
Like what's left over, right? So it's similar. They're going to go back to prodromal, but they also now have a flat affect. What's a flat affect?
Flat
Yeah.
face.
And flat means, I am so happy to see you today. It has been a while.
No emotion in the face.
Right. And at this point, they have an inability to function. Like they need a social worker. They need somebody, like they either need to be inpatient somewhere or somebody has to be caregiving for them 24 hours. Okay. All right. You understand the basics of schizophrenia?
Yes.
Okay. All right. There are so many symptoms of schizophrenia.
Yeah.
So I did this as an interactive sheet so y'all would actually pay attention. Okay. Otherwise, I kind of lose you if I just read to you. So we're going to go through each of these. I would recommend kind of putting down some keywords of what they are and then giving yourself a little example.
Okay.
Okay. Now, there are positive symptoms and there are negative symptoms of schizophrenia. Positive, I think, is something that they are adding that you should not be adding. And negative symptoms are something that they don't have that they probably should. Okay. Like you could put flat affect and negative. They should have emotions on their face, but they don't.
Mm-hmm.
Okay. Positive is going to be things that they have that they shouldn't, like delusions, hallucinations. Y'all see the difference?
Yeah.
Okay. So how I did this, because I ran out of space, quite honestly. All the positive ones are over here, and then I had to add some more over here too. Okay.
Mm-hmm.
So if they're an orange or blue, they're going to be positive, and then these ones down here are going to be the negative symptoms. Okay. And this is about to get really weird, so I'm just going to let y'all know that, because some of these symptoms are wild, and I'm actually pretty good at telling you what they are. So let's see what happens. Okay. All right. Anything I do from here on out, I'm just acting. It's not happening in real time, okay? Yeah. Okay. So y'all don't be like, well, somebody call 911 on this woman, okay? All right, so we're going to start with our positive symptoms. Explain to me what are positive symptoms.
Symptoms that should not be there.
Okay, so there are ones that symptoms that they have that should not be there. They have added them, but we're like, that shouldn't have happened.
Mm-hmm.
Okay. All right, so let's start at the top and see if you know any of these or see if we can figure them out. Okay. What are sorry, let me start over. We have categorized these as well. These are positive symptoms that are problems with the way that they are thinking, content of thought. Okay? Content, the content of their thoughts, the meat of their thoughts. Okay. So delusions, what are delusions?
What they think.
All right, so it is abnormal, like things that they think are happening to them or beliefs that
aren't true.
Well, I don't know if they're true or not. They could be true. I really don't know.
Yeah.
But like from a layman's perspective, they're probably not true.
Yeah.
Like they may say something like, I can't go get in the shower because there's radiation coming out of the shower head.
Mm-hmm.
But that's probably not true.
Yeah.
Okay. But I never want to discount what schizophrenia people say because I don't know, especially when they claim that they're getting sexually assaulted or something because they claim that a lot. But people know that they claim that a lot, so I feel like some people take advantage of that and they do abuse them.
Yeah.
So I'm never gonna discount that. All right, religiosity. What is religiosity?
Religion?
Yes, but like to the point where they're like taking on the religion, like I am Jesus. Okay. So they have very big religious beliefs and they're not usually associated with a certain religion. Okay. It's more like I have come to set the people free, Okay. All right. What is paranoia?
Paranoid about like someone gonna kill them or something?
Yes, they think everyone is after them and they're suspicious of everyone, which this is what makes them violent. So I want y'all to understand that these patients are probably one of the most violent you will encounter. They are unpredictable, and even if you have a very good relationship with them, they could harm you at any time because the voices told them to do so.
Yeah.
Okay? So big things you need to remember for schizophrenia is you should always be between the door and the patient. There should never be a time where the patient is closer to the door than you. Because if they do try to harm you in some kind of way, you need to be able to get the hell out that door, right? And the first thing you will always do when you step in a room is turn on the light. Because it's often they call out at nighttime, so you may feel like you need to run into the room to find out what's wrong. I'm flipping on that light because I'm not going to walk in there and they got my scissors like, beep, beep, Okay? All right, magical thinking. What is magical thinking? We talked about this in PD.
Thinking about
it's preschoolers that think that have magical thinking. So they think that like their thoughts like can control everything. Like, and it's so, everything that they do is so magical. Like, yeah, I can grow you wings if you're interested.
Yeah.
Give me some, I'll think about it and I can get that for you. They think that they can like do all the things. Okay. All right. So the next ones are going to be form of thought. Okay. So this is how they are, these thoughts are going on in their head and now they're coming out their mouth. And I'm going to try as best as I can to do them for you. Sometimes I messed up, but I'm going to try. All right. Associative looseness. What does that mean? It does. They associate concepts, but very loosely, and they really shouldn't be, right? Like if you were coming in to talk to me and I had schizophrenia, okay? And I was like, hey, did you know that I had a cat? The cat was in the hat. Did you see the cat in the hat? Have you read that book before? Gone to a library? Have you been to a library before? Library, lie, lie, lie. My mom used to lie, lie, lie. Can you follow it? Kinda. Like you see where they're going, but they're very loosely associating things that didn't really make sense.
Okay.
Okay. So what you gonna write in that blank?
No.
So you could write what I wrote was like, I have a cat in the hat at the library. My mom lie. Like something like that to where you'll be able to look at it later and be like, I know exactly what she's talking about. All right, next one. Neologism. What does neo mean?
Baby?
New. Well, kind of new. Neo means new. So they make up preschoolers do this too, actually. They make up words for things that don't exist. Like, oh, can I have your snarkle-flit? Sorry, my what? Right there, your snarkle-flit. Well, that ain't a word. Okay, like that's what it is. It's making up new words. Okay. They have very concrete thinking. You will also see this in preschoolers. And I'm not trying to make them childlike or, but
yeah,
you will see some of these thought processes. What is concrete thinking?
Like,
and that's hard to explain.
Yeah.
Like something very specific?
Like very black and white.
Yeah.
Okay. Like it's black and white thinking. You're good or you're bad. Or whatever you tell me, I'm going to take it very literally. So if you went into them and said like, I need to take your blood. Where are you taking it? You can't take I knew you were trying to take my blood. And then it would feed into all their suspicions and all, you see what I mean? Mm-hmm. So you have to be careful because they are very concrete thinkers, very black and white thinkers. They're not going to understand like nuances and, different kinds of phrases that you may use. They're not going to get that. All right. Word salad. That one's fun. Word salad.
Say a bunch of random
yes.
words together.
I went to the shirt of the Niner 5-8-7. Cup napkin. Yeah. Okay. So a bunch of words just get tossed all together.
Yeah.
Circumstantiality. Okay, they add like a ton of extra circumstances. Have you ever like gone to lunch with somebody or known somebody who you want to have a conversation with them, but they give you so many like details that are totally not important to the story and you never can get to the freaking story? That's what, she's like that. Hopefully she doesn't watch this recording. Circumstantiality. So that would be like if you and I were having a conversation, you're like, hey, I heard you went to a wedding the other day. I did. I went to this wedding. Oh, well, first of all, you gotta think it was on a Thursday, right? So Thursdays, superstitious. It's kind of crazy. So anyway, so it was on a Thursday and we decided we were going to drive there. So we got in this like truck, this like white truck, but like, how like engines on trucks can sound kind of funny sometimes, So I was just thinking about the truck's engine and like, how are we going to get there? Are we going to get there? Are we not? And this will go on for a very long time.
Wow, they do end up to the point like
they will.
Going back, right?
Yes, but it still is difficult. Okay. So in circumstantiality, okay, explain to me in your terms what that means. The one I just did with you.
Elaborate about like every single thing about like something maybe.
You're giving too many details,
yeah.
Okay? So yes, I wore a white dress. It had 7 buttons on it. Each one of them had 6 stitches. There were 6 stitches on 7 buttons.
Too much information.
Okay. And tangentiality can kind of look like that as well, but they will just start to wander off topic. So let you and I can have a conversation. Okay, so ask me about something. Ask me about anything. I really don't care.
How was your day?
Huh?
How was your day?
Oh, my day? It was good. Do you know what my favorite day is? Saturday. Why do I like that? It's Saturday. It just sounds like a good Saturday. It sounds like a good day, doesn't it? I sat on your day. You get what I'm saying? Sat on your day. Yeah. So Saturdays are my favorite days, but yeah. So, today. You asked me about today. Yeah, today was a good day. Day's a weird word, right? Like if you say it a bunch of times, like day, it's like that. Okay. All right. Mutism. It is what
Don't
it
talk.
says it is. Yep. So you may say, how was your day? And they would say,
Nothing.
and what do you do in that case? Because this is actually a very good example of therapeutic communication. No, you say nothing. You use silence. You're just like, hey, how was your day? How are you doing? And they say nothing. You're like, huh. And then you want to bring up something totally irrelevant. I do this with children too, when they don't want to talk to me or when they're mad at me. I do it with my kids. I'll say something that I know that they may be interested in. Now, on an exam, it may say something like, oh, I heard the weather's going to be sunny today. And you can say something like that. And just kind of wait and see and use silence. And that's fine if they don't want to talk, right? But you can also say something that might interest them. Like if you know they're interested in rocks or something, be like, oh, I saw a purple rock on my way here today. You just leave it at that and see if they'll bite. But if not, you just leave it at silence. Okay? Okay. Perseveration. What is not preservation, perseveration.
Keep stuff to themselves, but just
Not to preserve. It's called perseveration.
I don't know.
Okay. So to perseverate means to get, basically it's kind of like they get fascinated with one thing and they keep repeating that one thing over and over again, even though you've already like moved on. Okay. So they use repetition of something in the context where it's like not really appropriate to do so. So let's say, I actually seen people do this that are not schizophrenic. If you're having a conversation, there's a bunch of people, like we're all sitting around, we're all talking, right? And I'm just like, oh, hey, how's your mom? And then you're like, oh, remember my mom passed away last year? That didn't really happen. I'm just saying. Oh, right? That didn't happen. Did that happen to you? Okay. Because you're looking at me like it did. Okay. So, and then I was like, you were like, oh, remember my mom passed away last year? And I was like, oh my God. Oh, I'm so sorry. And I'm like, so, I heard you went to a birthday party, like you're going to change that because it's awkward. And then there's that one person, your mom died? Really? When? What happened? Stop. We went past it. And so they get stuck on one conversation and cannot get off it, even though it's awkward and we've already all moved on. That's what that is. Okay. What are hallucinations? All right. So one of your 5 senses is activated for something that is not actually there. Echolalia. What is that?
Never heard of it.
Never heard of it. I don't know. Repeating someone. Okay, there it is. So echolalia is when you sit down with them to do therapy and they just repeat back to you everything that you are saying. Okay. Kids do that too, right? Yes. Stop copying me. Stop copying me. That's that. Okay. Echopraxia. What's echopraxia?
Repeating someone's like motions. So yeah, repeating someone's movement?
Repeating like whatever somebody is actually moving and doing, you are going to repeat that. This session is wild. Are we having fun? Yeah. See, PD's not all that. Okay, no, it is actually. I actually love that class. I was gonna say, yeah. Are you taking a PD class, by the way?
Yeah. But not this semester.
But you're going to.
Yeah.
Okay, it's so fun. Is that your favorite one in here so far? Yeah. Yeah. Okay. Depersonalization.
They feel unreal.
Yes. They feel like they are living in a world that is not real. And honestly, they kind of are. Yeah. Because the stuff that they see around them, that isn't real, but they see it as real. So then they themselves think, well, then I must not be real. Right? All right. Thought broadcasting. What does it mean? Like if you're turning on a radio and it's broadcasting.
Oh, like saying everything they think?
They probably will say everything they think, but they think that their thoughts are getting broadcasted to other people. Okay. So I'm sitting here thinking like, you are funny looking, and then in my brain, and I'm like, oh my gosh, she freaking heard me say that. So they're like scared to say or do anything because they think that all of their thoughts are getting like, how y'all, that is like one of my worst fears. Can you imagine? Oof. Yeah, I know. Like, I would have no family, no friends, no nada. Okay, that's bad. That's what thought broadcasting is. All right, thought withdrawal. They think that somebody can remove their thoughts from their head. So they try to hold on to those thoughts. And that's why sometimes they'll perseverate on things and think about them over and over again, because they think at any moment somebody could just come and grab this right out of my head. Okay. And then thought insertion, they think that people can
Put stuff
implant thoughts in their head, so they're very careful. That's why a lot of times, like, you know, in movies and stuff, it's not really like this in real life, but they'll show them wearing like a helmet or something because they're trying to keep their thoughts from being either broadcasted or inserted or withdrawn. All right, let's go over to the negative symptoms. What are negative symptoms?
Stuff that they should have.
Yes, they should have, but has been taken from them because it's negative. Okay. Like a flat affect. What have you learned a flat affect is?
No emotion on their face.
No emotion on their face. So you sometimes have to just read the context clues.
Yeah.
Yeah. All right. Alogia. Anybody heard of this one before? Okay. Well, I have a teenage son. He's 15. And this is how I feel when I text him and he texts me back. Because I'll text like, oh my God, mommy loves you. Have a good day. Okay. Okay. So alogia is what they call like poverty of speech, which basically means like you can talk to them and there you ask them a question and they give you one word answers. Mm-hmm. So if I showed y'all like the text messages between me and my son, it'd be like me, like big pair, and then he's okay, okay.
Thumbs up.
Okay. Yeah. So that's what that is you might ask them like these, you know, long questions and they're only going to respond with nothing, yes, no. I know people like really that do that though. All right. Avolition is a lack of motivation. Dude, I would not feel motivated either if everywhere I went I was hearing things and seeing things and tasting things and feeling things. Mm-hmm. They obviously have very impaired social interactions because all these things can make it very difficult to sit and have a conversation with someone. If all I've been doing this whole time is looking behind you and I see a big, giant, 10-foot tall monster, I'm not going to be able to have very good conversation with you because all I'm doing is looking in that freaking corner, right? All right, waxy flexibility. This one wild.
Like very flexible?
They're not very flexible, but they get stuck in certain situations. You know, like waxy, like a wax figure.
Oh, okay.
So you may come into their room and they are stuck literally like this. And you try to bend them and you cannot.
Interesting.
Like a wax figure. And sometimes they get stuck in really weird positions, like exorcism positions, like, you know, backwards. You know what I mean? All right, what is posturing? They're standing, but they're usually standing in an uncomfortable way, but they're just like stuck and sitting in it. Waxy flexibility is usually like mat. Like you'll walk in and they're like twisted on the bed. This one is kind of a form like that, but you can tell like they're just in like a, maybe they're sitting like this, but they haven't moved for 3 hours. And you're like, I know that hurts, you know, like that can't feel good. Pacing or rocking, but not in a violent way. This is more like a self-soothing kind of way. Okay. So you may see them in a rocking chair, catatonic. You know, anhedonia. This is a very common symptom in lots of different mental disorders. Does anybody know what it is? Yes, it is a lack of pleasure in things that they felt pleasure with before. So they used to really enjoy, you know, boating or fishing or, you know, and then now they don't even want to do that anymore. What is regression? Yes, it's going back to doing things that children would do. Like you'll see the pacing, the thumb sucking, the rocking. And that's a form of self-soothing. I would want to self-soothe myself too in this case. And then they become very, very socially isolated because, of course, all these symptoms are very difficult to get along with other people. Yeah? Mm-hmm. Okay. All right. So we're going to talk about nursing care. Safety for yourself is first, which means you should always be between your patient and the door. What are the most dangerous type of hallucinations that these patients can have?
Visual? No.
I'm not talking about one of the senses.
Oh.
You know they hear things, right?
Oh, like telling them to do something?
Command hallucinations, because you always want to ask them. What's the question you want to ask? What are they telling you to do? Because if you can tell, like, you'll be able to tell when they're, because they're like, what? And you're like, do you hear something? Are you hearing something? And they're like, yes. Are there voices? Yes. What are they telling you to do? To stick my scissors in your eye. Oh, that's good to know. Take care. Okay, I'm out. Okay. So that's why the command ones are the most dangerous, but you always want to ask,
what are they telling you?
What are they telling you to do? Okay. All right. For as far as nursing care, the first thing you do is to assess yourself. You will always pick that on nursing school exams or NCLEX. Because can I take care of a schizophrenia patient? Do I have too much of a soft spot for one to where I feel like I won't be safe? Or do I have some kind of bias against because I had a bad experience before? And this can happen a lot in psych nursing, right? Because maybe a schizophrenia patient attacked you before. And so like, you're like, I'm sorry, I just can't, I can't give him a non-biased care because I'm going to be scared the entire time. I need a different assignment. Okay. So you want to assess yourself first. And then priority number 2, once you walk in, safety is first. Always turn on the
lights.
Stay by the
Door.
Do not ever turn your back to the patient because they might attack you. Okay. Number 3 is to build rapport. What is rapport?
A relationship.
Right. And how do you build trust with that patient? Talking to them, communicating with them, not telling them that what they see isn't real.
Yeah.
Right? And providing a safe spot for them. You want to provide a safe space, which for them, and this is the only time in psych I'll tell you to do this, is to distract the patient. Okay? In bipolar and anxiety and depression, you can't distract them from the terrible things that are happening causing the depression, right? It's not like, their husband died. You can be like, oh, look over here. That doesn't work, okay? But in schizophrenia, because they are afraid of what's in front of them, and what's in front of them is so real, the only thing you can do is, let's go out. Yeah, let's go in the hallway. Let's go to the day room. Let's go take a walk and get them out of that situation, okay? And then you're going to develop a therapeutic milieu. What's a therapeutic milieu? Yes, so it's like a summer camp for psych, right? So they come in and you're like, hi, it's orientation, right? My name is, and I'm going to be your nurse. Good, okay. Ma'am, you are not a teacher, okay? I'm going to be your nurse today. Here's your room. Why are you still a teacher? Have you ever been a teacher? What in the hell is happening to you? Oh, okay, maybe that's why. So this is your bed. This is your roommate. Hey, this is the cafeteria. This is where you're going to have all, you're like orienting them to the environment. Okay. All right. Safety. Make sure you keep it professional, not personal. You do not tell them anything personal about you ever, even if you really like the patient. And sometimes it can be really hard because you do develop a very good relationship with them. Okay. Yeah. Keep the end goal in mind. What do I mean by that? Oh, I haven't taught you yet. So what I mean by that is when they're asking you a question about a schizophrenia patient says this, what do you do or what do you say? The way we communicate with them is totally different than any other disorder. And that's why people get this one really messed up. They believe what they believe, and I cannot change those beliefs. So you have to just think, what is my end goal? And then how am I going to get to it? Okay. So for instance, we gave the example of the patient will not take a shower because he thinks there's radiation in the shower head. And everybody in the group is complaining because he smells so bad. He hasn't showered in 2 weeks. Okay. So you go up to him, you're like, look, we need to shower today. Okay. And he says, as soon as I get in that shower, that radiation is going to come right out of that shower head. So what you going to do? What's your end goal?
For him to shower?
For him to, I don't care if he showers. What's our end goal? What are they all complaining about?
That he stinks.
Okay. So my end goal is I just need to get this dude clean. I don't care how I do it. He just needs to get clean. So what are some other ways that we can get him clean?
Wipes?
Sure. Or, okay, how about I bring you a bucket of water and I'll get you some soap and we'll do some water and you don't have to go in the shower, but we can just do it out here. I'll close the door and make sure you have some privacy. I just want the dude clean. Okay. Right. So you always have to think of the end goal in mind. Do not try to convince them. There'll be answers like, show him that there's no radiation in the shower. No, these beliefs are their beliefs, right? What they see is what they see. So you can't be like, don't worry, it's not that. Yeah, it is. Yeah, it is. So I just got to keep my end goal in mind. And that will help you so much when they ask about therapeutic communication with your schizophrenia patient. Okay. So this is how you communicate with them. You're going to say, I don't see it, but you look really scared. So distraction.
Let's go to the
That's it.
hall.
In that order. Okay, that's exactly how you're going to communicate.
Mm-hmm.
All right. Involve the family in all aspects. Okay, you're going to need a lot of family help because if they ever hope to get out of the hospital, the family's going to have to take care of them. They cannot take care of themselves on their own.
Mm-hmm.
Okay. Our 2 big goals. Number 1 is medication compliance. And what medication do we use for schizophrenia? You need the big daddies. What are the big guns here? It's way stronger than that. Strongest psych meds we got.
Oh.
Anxiolytic?
Way stronger than that. Psychotic. Thank you. We're going to do antipsychotics. Okay, remember there's 1st gen, 2nd gen.
Mm-hmm.
And if y'all don't know them very well, you need to go back and study them. All right. So medication compliance is very important because they're always going to hear the voices and they're always going to see things, but this can decrease it enough to where they can actually carry on a life.
Okay.
Number 2, we're going to try to prevent relapse. And how do we do that? By doing goal number 1. Medication compliance, right? And teaching them how to live with these delusions and hallucinations. Like, for instance, we'll tell them if you keep hearing the voices very loud in your head, put on headphones with loud music. It'll drown out those voices.
Okay.
They're going to hear loud stuff anyway. Might as well hear like rock music. Okay. We will tell them if you see something, ignore it. Okay. It's not there. You know it's not there. You know, when they're not off their meds, they don't know it's not, they know it's there. But once we get them on their meds, our goal is not to get them not to see it because that's not going to be possible. Our goal is to get them to see it and know that's not real and just keep moving on.
Oh, so when they're on meds, you do tell them that it's not real?
No, you don't tell them that it's not real, but they'll eventually see like, okay, I know that that's not real.
Oh, they'll say
yeah,
it.
they'll say it. They'll eventually see it. So that way you get them to recognize, okay, it's a big, giant 12-foot green man in the corner. Chances are that's probably not real.
Mm-hmm.
And then you just keep moving on.
Yeah.
Okay.
Okay.
All right. You want them also to perform their own ADLs, to create social relationships. And we do that by giving them a job on the unit, something very low key. Okay. You're not going to give them the job of like party manager on the unit. Okay. You're going to give them something very small, like setting the tables or something like that. But we do want them in group therapies. They learn how to develop social relationships. Okay. We want them to learn to trust others because remember, they're very, very suspicious, right? Okay. So involve them in a group. They're not going to like it and they may not speak at all in the first several group sessions. That's fine. You don't have to talk, but you are going to be around other people. Okay.
Mm-hmm.
An option for like low key too would be like playing a game with somebody in the day room, but something where you don't have to talk, like checkers, Connect 4, something like, so you're doing something with another human, but you don't have to speak about it. Okay. For the hallucinations, we're going to ask them directly, what do you see? Because I need to know if it's something that I need to be scared of. Okay. You can always say, I don't see anything, but
what do you see?
You look scared, or what do you see? Yeah. And if they've already told you, then I'll say like, you look, yeah, let's go. Okay. Focus on their feelings. You look scared. You look angry. You look, whatever it is that they're feeling about whatever this thing is. Okay. Most dangerous, remember, are the command hallucinations. And you first want to ask,
what are they telling you?
What are they telling you? Okay. So ask what the voices are telling them to do. Focus only on reality. I don't see it. Okay.
Mm-hmm.
And then we distract. And then after the whole episode is over, later on, we will start to identify their triggers and learn how to avoid those. Okay. Be like, boy, every time your mom comes to visit, you start having these really bad. So what are we going to do for next time? Does mom need to not come for a bit? Right.
Mm-hmm.
Okay. All right. As far as treatment, individual and group therapy is important. We'll do behavior therapy because they've got to be able to learn how to get along in a group. Right.
Mm-hmm.
Social skills training, so we can teach them how to have friendships, which I think is kind of sweet. Mm-hmm. Family therapy, very important. Does anybody know what assertive community treatment is? Can we send them just home? No. So usually what this is they will go somewhere all day long and be in a facility, and then they'll get to go home during the nighttime. So that way they can kind of, they can still integrate into life, but it is very, very like, I'm going to take care of you and make sure you're okay. Or sometimes they'll do it the opposite way. If they're really doing very well, then they'll get to go out, work during the day, and then go to the hospital, spend the night at nighttime, get their meds, that kind of thing.
Mm-hmm.
Social worker, you have to. They will not have food. They will not have ways to pick up their medication. They'll forget to pick up their medication. They'll not want to pick up their medication. And the medication compliance, of course, is a really big deal. Okay. Mm-hmm. All right. As far as nursing diagnoses, disturbed sensory perception. What does that mean? Their senses, right? Don't they have 5 different senses that have
Yeah.
different hallucinations? Okay. Disturbed thought process. Give me some examples. What are the new words you learned today? Neologism.
Mm-hmm.
Word salad. Okay, that's good. All right. Social isolation, of course, right? Of course they're going to have social isolation.
Yeah.
Risk for violence. Y'all got to be real careful with these patients. Okay.
Mm-hmm.
Impaired verbal communication. They're either
Flat.
and mute or word salad, right? And saying all kinds of things that you're like, what? Self-care deficit. They don't want to bathe. They don't want to shower. They don't want to do none of that.
Mm-hmm.
I wouldn't either. If the government was after me, shoot, I'd be like, you know what, you're going to get me. You're going to be smelly. And then disabled family coping. Do y'all know anybody that has schizophrenia?
Mm-mm.
It is very, very difficult on the family because no matter what you do, this patient cannot take care of themselves and they're very erratic behavior and you try to show love to them and they unfortunately just cannot accept it. And it's very, very, very difficult.
Yeah.
So that's why we do family therapy as well.
Is there like a age that this usually like
Presents?
Yeah.
Yes,
or-
that's a great question. It's usually around puberty or early teens, late teens, early adults.
Okay.
Yeah, it usually is pretty early on, which is really sad.
Yeah.
Questions?